family physician. This is a live question and answer live stream with Dr. J's Prescription for Health. This is my assistant. He is co-hosting from heaven. This is Tucker. Tucker is my co-host from heaven. So he's helping me out. All right, today we got, I'm guessing, a lively discussion. We had a request, as we were closing yesterday, we had a request to discuss LDL cholesterol and the new PCSK9 inhibitor, the new oral medication. So while we're waiting for everybody to jump on here, we are live on YouTube and Instagram. Welcome, everybody. We will get started here in a second. If you are listening on Instagram or YouTube, let me know where you're listening from. What city, what state, what country? Let me know. All right. Let's see. Toya says, haven't been here in a while. Always love your content. Well, thanks for rejoining. I appreciate it. We always are happy to have you back. I know it's easy to drift away, but today's your lucky day, I'm hoping, and you get some information out. So good morning, Virginia. Thanks for being here. All right. So today, because when we were closing yesterday, we had someone ask about the new PCSK9 inhibitor. It's an oral. The name is called Lipfendra, Lipfendra. The other name for it is Enclicitide, 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 Enclicitide. When it's a brand name, especially since it's going to be a new medication, we call it by its brand name, Lipfendra. And it's oral. It's a once a day. It has to be taken on a empty stomach. It is a PCSK9 inhibitor. It is a peptide, and it is a small protein, a smaller protein peptide, compared to the injectable PCSK9, which is Repatha. Many of you have heard of Repatha or Praluent. That's another PCSK9 one. I guess depending on the dosing schedule, one is once a month, one is every 2 weeks. PCSK9. PCSK9 is a particle that is in our body from the liver. PCSK9 will prevent, well, let's back up. Let's back up. I need to explain everything, okay? Your liver makes cholesterol. It will package cholesterol and triglycerides in a VLDL. And the VLDL is sent out into the bloodstream so it can deliver the cholesterol and the triglyceride, the energy, to areas that need it, okay? And that VLDL, when it dumps off the cholesterol and the triglyceride, it becomes an LDL. And then the LDL, empty of its triglyceride, will deliver the cholesterol to cell membranes and muscles and all of that. And once the LDL has dumped off its cargo, it recirculates back to the liver and attaches to an LDL receptor so it can get back inside the liver. And what does it do when it gets back inside the liver? The liver can decide, do I need this LDL? So it'll recycle it, or do we not need it? And the liver will send it out into the gut to, well, in bile, to be eliminated in a bowel movement. That is a natural process. Now, let's say you are a person whose LDL receptors are not very many. And so if there's not very many LDL receptors, then all the LDL in your bloodstream can't get back to the liver. It has to maybe circle the home, It circles the home waiting for a door to open so it can get inside. If you give a PCSK9 inhibitor, you're going to inhibit PCSK9. Why would I want to inhibit PCSK9? Well, PCSK9 actually tags an LDL receptor for its destruction. Not all LDL's receptors, they're not all long lasting. The liver can decide, hey, is this LDL receptor worthy of recycling, just like the LDL, or should we just destroy it and we make more LDL receptors? Well, PCSK9 tags LDL receptors for destruction. So if I inhibit PCSK9, more LDLs will be on the surface because they're not being destroyed. Is this making sense? It will allow more LDL to come out of the bloodstream and into the liver. So this new medication, Lipfendra, is an oral, smaller peptide that is taken on an empty stomach on a daily basis. And when we hear the term peptide, it appeals to our senses as, oh, well, this is good for us. Peptide. We give peptides all the time. We give Ozempic and Wegovy and Trulicity and Mounjaro. Those are all peptides, aren't they? Isn't BP whatever 157, isn't that a peptide? Aren't those good for us? Well, how do we know? Have we been doing a whole bunch of studies? I don't know. That's not what I'm here to discuss. But you can tell where if I say the word peptide, you think of a positive connotation. Well, everybody's on peptides. Peptides are good for us. Our body makes peptides. There's what is bad for us. I don't know, but could there be something bad? Sure. My thought process when it comes to LDLs. Now, you can argue, Dr. Jensen, you're just a family practice physician. You are not a cardiologist. You're not an interventionalist. What do you know? Why should I listen to you? Granted, that note to self, I would agree with you. Why should you listen to me? My goal for you guys is to get you to think logically and use your brain instead of just accepting someone's word for it. Why is it that we keep coming up with all of these medications? Why is it? Good morning, Lucy. Thank you for being here. I appreciate it. Lucy is my blue wrencher, my blue shield over on YouTube. And I do appreciate her being here every weekend when she can. So it means a lot. Steven says, hi from Fort Morgan, Colorado. Appreciate you sharing your expertise and enjoy listening. And again, Stephen, I really don't look at myself as an expert. I look at myself as just a continuous learner. I want to continue to learn about these things, and I want to get you guys to start using your brain and think through things, okay? If we have statins, and statins lower cholesterol, especially the LDL, which was considered bad. I can't fathom my belief that LDL, I believed it. I believed that LDL's bad. LDL's bad. We got to treat it. And it's as if God messed up on our body. I don't think so. Okay. I do not believe that God made a mistake on our LDL or anything in our body for that matter. But since we're talking about LDL and why we need to lower it and why we keep coming up with more and more medications, you have to wonder, with all of these medications, why is heart disease still the number one cause of death? Is it really LDL? I have people say, well, okay, Dr. Jensen, I understand about these statins. I would never want to take a statin. I've heard so many bad things. But what's the alternative? My question back is, why do you need an alternative? What is your diagnosis that you need or think you need something that lowers your LDL? What is your diagnosis? Well, doctor told me I have high cholesterol. Okay, know this. Cholesterol that's labeled on a piece of paper under your lipid panel is a calculation. Everything is calculated. You cannot measure cholesterol in your bloodstream. Cholesterol is carried in lipoproteins, VLDLs, LDLs, IDLs, HDLs. It isn't just floating freely in your blood where you can measure it. I'm looking at Buddy Blue. Anyway, so it is something that is calculated, as is the entire lipid panel. A more accurate way of determining your LDL or VLDL or your HDL or IDL, intermediate density lipoprotein, is to get an advanced lipid test, an NMR, a cardio IQ, whatever you want to call it. It will actually give you the lipid particle number, the size of your particles. That is more important, I believe, if you really think that LDL is the cause of your heart disease. Okay? This new Lipfendra has a study, and it's called I believe it's called the Coral Reef study. And in most, besides the US, it's already been approved in the US. It's not approved in the EU. It'll be approved somewhere in 2027. And the study is actually supposed to go to 2029. So 3 years, all right? It costs about $315 a month. But if you're so lucky, you could have your doctor give you a coupon and it could bring it down to $25 a month. We don't know. We'd have to do a prior authorization on you, okay? And it lowers LDL between 60 and 64% when added to a statin, okay? 60 to 64%. It's gonna lower your LDL cholesterol, assuming that your LDL cholesterol is bad. Now, why would you even add a PCSK9 inhibitor? Well, doctor, that seems easy. It is, you're not at goal. Your statin, even at high doses, didn't work. It's not getting you to goal. Who made up the goals? I'm not sure. American Heart Association? American College of Cardiologists? The American Diabetes Association? Who made up the goals? Why does the goals keep lowering? Do we really need more medicines? Do you need a PCSK9 inhibitor? Well, I don't know. I would ask, do you have something wrong with your PCSK9? Is your PCSK9 too high? And it's destroying all of your LDL receptors. Well, doctor, does it really matter? If LDL needs to be lowered, why don't we just take it? What could hurt? I don't know. What if you had all of this LDL coming back to your liver? That should mean that your liver knows what to do with it. What if there's so much it doesn't know what to do with it? Could it cause fatty liver disease? Could it cause increased liver problems with the hepatocytes? So many questions that your doctor isn't even going over with you. You've never gone over it. You don't know because you've never had the test. So if you happen to ask for a PCSK9 gene value level, your doctor is going to go, it doesn't matter. I hate when doctor, it doesn't matter. We just need to get your LDL down. Well, why, doctor? Because LDL causes heart disease. Well, does it? Doctor, do you know people who have had low LDLs and still have heart attacks? Well, that's because they already had a problem and we couldn't revert. We couldn't save them. We could just prevent something, but it was just too late. I don't know, you guys. I just don't know if I can jump on board with that line of thinking. I mean, that just sounds like hocus pocus to me. I don't know. Maybe it sounds legit to you guys. I'm not sure. But, I guess, why should we be adding a PCSK9 inhibitor? Or let's just say, you guys, you know what? I don't really like those statin things. I'm just going to jump right to the PCSK9. As if it doesn't have any problems. Well, they said it doesn't. In fact, Dr. Jensen, I heard you say that, it could be hard on the liver, but they said it's actually good for the liver. How could it be good for the liver? Like, did you ask them? Well, what is it good at? Well, I don't know, but that's what they told us. The doctor will say that. Well, my goodness, I don't know about you guys, but I think I would want to really know what is going on. I don't want to just hear that, well, they said. Well, who said? Well, I don't really know, but whoever did the study. Well, who did the study? And who are they working for? I'm not telling you guys what to do. Of course I'm not. I just want you to gather up information so you know what is going on and can make a good decision. Because is LDL really the problem? How does LDL cause the problem? Well, if you're thinking, you'll say, well, Dr. Jensen, from my perspective, my reading, I think it's the smaller, denser LDLs. They're smaller. They can get through the endothelial lining. Can they? Is that size the size that allows them through? And how did they get past, the glycocalyx? How did they get through that jelly-like protective glycocalyx? I mean, isn't that supposed to keep things out so we don't die? So protecting the glycocalyx is in our best interest. Now, an LDL doctor who just lives and dies by LDL as the cause of heart disease will tell you that the overwhelming amount of LDL is what leads to injury to that glycocalyx. But yet we've never really proved it because it's never been in any studies. So if we injure the glycocalyx, now can the LDLs cause a problem? Well, not so much, because they actually have to be small enough in order to either go through the cell, which they would have to be let in. The cell would have to say, hey, we need you, come on in. Or go between the cells and get on the other side of the endothelial lining and then build up a plaque. More importantly, I think we should look at what damages the glycocalyx. What damages that glycocalyx? And if we know what the number one cause of cardiovascular disease is, I think we could probably correlate some understanding. The number one cause of coronary artery disease or cardiovascular disease is diabetes. And the reason we have a disease called diabetes would tell you that we have toxicity of blood sugar. Diabetes is a disease, and it's a disease of high blood sugar. So you must realize that high blood sugar is not normal. In fact, it has its own disease called diabetes. What is a normal blood sugar? Less than 100. Fasting, maybe between 70 and 80 is normal. Can just a one-time deal of eating ice cream or drinking once a month, a glass of orange juice damage the glycocalyx? And the answer is, do you guys know? The answer is yes, absolutely. So the glycocalyx must be able to heal itself back again, or else we would just have lots of injuries and then we would not have 0 calcium scores, right? So every time, even if it's once a month, you drink a glass of orange juice full of sugar, it's going to damage the glycocalyx. It injures it. And then the glycocalyx, if you don't continue to drink the orange juice or eat the ice cream or eat the cereal, then it heals and it's protective and it's thick. But over time, it can be destroyed, right? If you drank a glass of orange juice every single day, it destroys it, and then you repeat it and destroy it and repeat it and destroy it. Do you think it could just rebuild itself if it's continuing to be damaged? I don't know. But the likelihood is no, because the sugar is hurting it. The high blood pressure is hurting it. Alcohol is hurting it. Smoking is hurting it. Do LDLs hurt it? There's never been a study. We don't know. But people without diabetes seem to live longer without heart attacks than people with diabetes. I know that correlation does not equal causation. I get it. But I'm just trying to think through this and say, I think it would be in our best interest to keep that artery lining healthy, right? We need to keep the artery lining healthy. We need to keep our blood pressure down, okay? Well, yeah, but it's hereditary. Is it? Let me get an insulin level on you. If that insulin level is over between 3 and 5, you have insulin resistance. You have too high of blood sugar causing too high of insulin, and the insulin is inflammatory, and it's irritating the lining of your arteries. And high insulin leads to high blood pressure because of water and salt retention. Over time, that high blood pressure is hard on your heart, hard on the muscles of your heart, can lead to heart failure, can stretch it out over time for years and years, leading to destruction of your pacemaker cells in the SA node, so it can mess with your electrical system. So from the pressure, you can get heart failure. Over time, you say, but yeah, everybody over the age of 70 is going to have heart failure. Well, look at their blood pressure. Look at their insulin. They don't just get high blood pressure. Just because you're aging doesn't mean that you're going to get a disease. But over time, insulin resistance, smoking, I think probably consuming seed oils. You can think what you want. If you think seed oils are so good for you, then continue to eat them. If you want to consume bleached, hexane, washed, heated, not oils that come from a plant, it's your prerogative. It's your prerogative, and I'm okay with that. At least you had enough information that you could make a decision. Do seed oils lower LDL? Sure. But is that the problem? Is your LDL the problem? What I would say is that seed oils do more destruction than anything. Okay? I agree, Robert. Robert says seed oils are garbage and they put it in all processed foods. Processed just means man-made it. Man-made it, and here you go. Okay? Got some people listening from Florida. Thank you, Tracy, for being here. West Palm Beach, my first time here. Well, welcome. I appreciate you being here. If you have a question, I can try to answer it. Mountains of Glencoe, Scotland. Hello, Lord. Mary is from the state of Virginia. Let's see. I'm getting through, making sure we do not have any questions so I can continue moving on. Talking about insulin resistance. What is that fasting insulin number? Between 3 and 5 is optimal. 3 to 5. It'll cover just what you need. Asheville, North Carolina. Mom C. Mom C came here for the ferritin, but pleasantly surprised with this topic. Is that because you saw Iron Lady Doc and you thought, I'm going to listen, this is all about iron, which we have talked about in the past. But if you have a question about ferritin, we can try to answer it. But right now, the topic of choice was from a listener yesterday asking about PCSK9 inhibitors. Peaceful says, will GLPs improve your heart health? Will a GLP improve your heart health? What is it? Again, I like to ask questions because I like to get you thinking. A GLP is a peptide. It is normally produced in our bowels, in our stomach, okay? In our GI system. If you have diabetes, if you have obesity, you usually, I bet if we were to do a level, the GLP level in you will be less. GLP does increase insulin secretion according to their studies, but there's really never been a study shown in a human that it increases insulin secretion. And maybe that's a good thing, because do we want to treat a type 2 diabetic who is already hyperinsulinemic more insulin secretion? Do we really want more insulin? Likely not. What would be the reason a GLP is good for your heart? Well, it lowers, one of the things, it could lower your blood sugar. All of these things are actually anecdotal. And what I would tell you is, if you want to take a GLP for your heart, did you first think about what is causing the actual not healthy heart? Do you have high blood sugar that you need a diabetes medicine to lower your blood sugar? Or do you just stop consuming the sugar that raises the blood sugar? I don't believe that we are deficient in GLP until we become metabolically dysfunctional. So should we not increase, or basically increase, our metabolic health? If GLP is down in someone with diabetes and obesity, that means they're metabolically unstable. Do we just take more GLP and continue to be metabolically unstable? My thoughts are no. I don't want to live with diabetes and take a medication. I don't want to live with obesity and just take a medication. Okay? My thoughts are on the LDL is we really need to look at everything. If I have a patient who's got diabetes, I'm really going to be talking to that patient. And I'm really going to talk to them whether their LDL is 100 or 150. Because the blood sugar, the insulin, is causing inflammation in the arteries and causing injury to the lining of the glycocalyx and the endothelial lining. Okay? That injury is what is susceptible to a blood clot forming. And yesterday we spoke about, we had a really good discussion yesterday. If you guys missed yesterday's live stream, we talked about stress and how stress affects our cholesterol. It affects our mood, obviously, right? How it could increase our risk of having a heart attack or diabetes or metabolic syndrome and have normal LDL, well, what they would consider normal. And I don't even know who they are. I'm going to use that word. Whoever the powers of that be that gave the levels of LDL, saying it's good or it's bad. All right? When you look into what your body goes through when it is stressed, injury and blood clots are likely the main culprit in heart attack, cardiovascular disease. Thank you, Super Nana, for being here, listening from Northwest New Jersey, here for the first time. What I would like you guys to understand is we need to keep our stress levels down. We need to sleep better, 8 hours, getting restful sleep. We need to get outside. We need to get away from blue lights. We need to get off of our phone and our TV. We need to associate ourselves with positive people. We need to work on childhood traumas that lead to adulthood coping mechanisms that can be very stressful. That stress can elevate cortisol and adrenaline. Do you know what cortisol and adrenaline do to platelets? It makes them more reactive. And when you make a platelet more reactive, you make it more susceptible to making a blood clot. So could an angry, irritable, stressed out person have a heart attack just from getting angry and irritable and stressed? At that moment of irritation and anger, your platelets make much more blood clots than they do when you're not angry, irritable, and stressed out. Did you know that? That the platelets react to your mood and they become more active in making a blood clot. And then we should have a part of our body that breaks down those blood clots. We have a normal system of fibrinolysis, breakdown of fibrin, the clot mesh. So while you get angry and irritable and moody and stressed, your platelets are more reactive, making more blood clots that your body's having to work to break down. And if you are constantly mad, angry, and irritable, you're constantly having more blood clots. And if you have more blood clots and you're eating a whole bunch of sugar, thank you, Roxanne, you're eating a whole bunch of sugar, you made an injury, guess where that blood clot is going to go? 1910, honestly, I did not know it either. Again, this is from my reading, all just from trying to educate myself and share it with you. Who knows? Maybe in a year from now, no, platelets don't get reactive when you get irritable and mad and moody. Could be. I'm just throwing it out there. That could be why heart attacks are more common in people who get stressed out. You go snow shovel and you've only done it once or twice a year and you stress your system and you have a blood clot thrown and you have a stroke or a heart attack. Not heart attacks from LDL. You can lower your LDL. And I know, Roxanne, it does make perfect sense when again, I could be biased. Roxanne, I could be biased because I see so many heart attacks occurring in people who have on statins or on a cholesterol medicine, yet they still have, their LDL is like 50 and they're still having heart attacks. But nobody corrected their diabetes. Nobody corrected or talked to them about their mood and their mental health and their childhood traumas. Nobody. Does a doctor even look at the platelet count? Do they even look at the iron, the ferritin? Do they get a fibrinogen level? Do they check your risk of having blood clots? Do you have fatty liver? Well, fatty liver makes PAI1, which increases our risk of blood clots. Do you have an LP little a that's pretty high? Yeah, I've heard about that LP little a. Well, of course you have, because they're going to come out with a medicine that'll lower LP little a, even though they told you that you're born with genetically given level, but yet we can make a medicine that lowers it. Are we thinking? You first tell me that LP little a can't be changed. You only need to check it one time. Okay? But if you can't lower it, but I can make a medicine that lowers it, so then it's not genetic, or it is genetic, and we can lower a genetics thing? Okay, all right, we're on board. So it can be lowered. We just have to give your medicine in order to lower it. And it is a problem. Well, is it a problem? And when is it a problem? Do people with high LP little a always have heart attacks? No, but it's an independent high risk factor. Well, everything's kind of a high risk, independent risk factor, isn't it? What is it about LP little a? Well, LP little a, when there's an injury to an artery, let me guess, smoking, alcohol, blood sugar, insulin, diesel gasoline fumes, PUFAs, polyunsaturated fatty acids. Well, can LP little a be a problem then? Of course it can. Why? Because it's an injury healer. It's like a Band-Aid. It's like a blood clot. You want to have a blood clot if you cut on my skin, right? So when is LP little a bad thing? Well, if you have an injury that needs LP little a hand, if you need the workers to make a blood clot. Well, okay, that's a good thing, I guess. I don't want to bleed to death. You're right, Dr. Jensen. So do we just nonchalantly check an LP little a and say, yeah, we better treat your LP little a and bring it down. Here's your medicine. Yeah, but I'm metabolically healthy. My triglycerides are less than 70. My HDL's above 70. My insulin is 3.5. I'm metabolically healthy. Let's check a calcium score. Okay, I can get on board with that. Let's see if you have any damage in your arteries. Calcified soft plaque. All right, well, if it's 50 and you're not on a statin, it's bad. But if it's 50 and you take a statin and it goes to 100, it's not bad. So a calcification going up, or you get calcification, let's just say you had a 0 score and you go on a statin. You've never had a problem, right? Your score is 0. Your triglycerides are 55. Your HDL is 75. Your insulin is 4. And your LDL is 170. Here's your statin. You recheck a calcium score in 2 years and it's elevated. Well, that's because you're on a statin and you must have had soft plaque and it calcified it. So calcification when you're on a statin, good. Calcification when you're not on a statin, bad. Let's give you a statin to increase your calcification. I don't know. I mean, have you guys really thought about this? Wow. Kevin says, MD or chiropractor. I'm actually a DO. I went to osteopathic medical school. I took an MD residency and I took MD boards. Thanks for asking, Kevin. All right. Did I miss anything over here? You guys are really good on Instagram listening. Yep. No questions so far over here. Any questions so far? Do you have a question on LP little a? Do you have a question on LDLs? Do you want to know the size of your LDLs? Would that be a good thing? Is it possible that you have a low triglyceride, 50, high HDL, 75, and a high LDL? Could you possibly have high, small, dense LDLs? The thought would be no, that small dense LDLs are only made when there is a high amount of VLDL. Does that make sense, or should we back up? I know for some of you who are listening for the first time, it is very important to understand the process of the liver packaging up energy, triglycerides, and cholesterol, okay? In a normal process, how I started this out, the liver packages up cholesterol and triglycerides into a VLDL, very low density lipoproteins. If you have low amounts of triglycerides, you're going to have lower amounts of VLDL that need to be packaged up with cargo, because if there's not very many triglycerides, you don't need a whole bunch of VLDLs to carry that cargo that's not there. That's why the VLDL would be lower. If your triglycerides are over 100, you're going to need more VLDLs to package up that triglyceride and send the energy out into the bloodstream and feed whatever needs it, like the muscles or your cell membranes. But if the cells don't need any energy and you have too much, it continuously will be in VLDLs. Now, VLDLs are trying to dump off that energy, and they can't. But if there's a lot of VLDLs, there's also a lot of LDLs. An LDL can't get there without a VLDL, right? So if you're building up VLDLs, you're building up LDLs, they can get so high in the bloodstream that they bump into each other. They collide. There's a major collision. It's a pileup on the interstate. And there is an enzyme called CETP. CETP will be the moderator for the VLDL to dump triglycerides back into the LDL. Remember, the LDL had already been emptied of triglycerides. That's how it became an LDL. The VLDL had the triglycerides. It dumped it off to the areas that needed it and become an LDL. Had to dump off some cargo. That cargo was the triglycerides. LDLs are not supposed to have triglycerides in them. They carry cholesterol, but not triglycerides. All right? If an LDL gains triglycerides via that CETP, that enzyme, the LDL will take on triglycerides and it will actually give cholesterol back to the VLDL. Now that LDL is in an exposed LDL. He's like he's naked. He doesn't have not much cholesterol, and he's got triglycerides in him, which is very dangerous for an LDL. And so that LDL can become oxidized, damaged. It becomes damaged and it can become a small, dense LDL. So how did we get the small, dense LDLs? High VLDLs. How did we get high VLDLs? High triglycerides. How did we get high triglycerides? High blood sugar. Can you get high, small, dense LDLs in a person who eats and has normal blood sugars? I've seen it. Those are my carnivore people. I will get you guys who are carnivores or very ketogenic, low carb. You're in ketosis, you're on a very low carb diet. If a carnivore is eating a massive amount, what do I say by massive? Let's just say they're eating 100, 150, 200 grams of fat every day in their ribeyes, in their New York strips, and their butter and their eggs and all of that. Can they have high LDL? Absolutely. Can that be a problem? Absolutely. Why? Because the high saturated fat will decrease LDL receptors on the liver. Saturated fat lowers the amount of LDL receptors on the liver. So If you are eating a bunch of saturated fat and the liver is packaging it up as triglycerides and LDL and sends it out into the bloodstream. Remember, they're not eating very many carbs, so they're not going to have very many VLDLs, but they're going to have some, right? Because they got to get rid of the fat somehow. But generally, that fat should just be used as energy. People are, they're exercising, their brain needs it, their cells need it, everything, and all is good until it's not. When saturated fat is so high, it lowers the LDL receptors. So now the LDL can't come back. The doors on the house, the windows and the doors are locked on the liver, and they can't take in any more LDL. So the LDL just stays out there circling. It's not damaged. It's not anything. It's just circulating. So many doctors will say just the mere fact of that LDL being elevated causes an injury to the lining of the artery. I disagree. I don't think that LDL alone, pure amount of LDLs, is enough to cause an injury. What I do think is that because of the sheer amount of LDLs, and even the very few VLDLs, they're going to bump into each other. You could get a C-type reaction even if you don't have very many VLDLs and you have a ton of LDLs. This is my theory. Have I found a study? But I'm just thinking through, why would a carnivore person, truly carnivore, okay, their triglycerides are pretty low. Their HDL is over 70, yet they have small, dense LDLs. They did something, had to make that a small, dense LDLs. I think it was the collision. So what does that person do? Do they go on a medicine? Does the carnivore person who I got an NMR on, who's got extremely elevated, let's say 400 LDL, and I get an NMR and they have a lot of small, dense LDLs, am I going to give them a medicine? Well, maybe I should just ask you this question. Instead of a medicine, can I get that person to get their small, dense LDLs down? Yes, I can. Do they have to go off carnivore and add carbohydrates? Absolutely not. The carbohydrates and their high-fat diet will make even more small, dense LDLs, okay? So my goal for these people would be lower your saturated fat. You don't have to go off a carnivore. Just lower your saturated fat. Instead of a ribeye or a New York strip, you want to consume a filet mignon. Instead of 80-20 ground beef, you might want to choose 93-7 or 90-10 ground beef. Instead of a stick of butter, you might want to do a quarter stick of butter. Instead of a dozen eggs a day, maybe you do 6 eggs a day. Yeah, but Dr. Jensen, now you're lowering all my fat, and fat's good for my brain. I don't disagree. So what fat can we add to you to make up for it that won't affect your LDLs or affect your LDLs in a good way? That would be monounsaturated fat. Well, what is that going to make a difference? You telling me to eat plants, get monounsaturated fat? I didn't tell you to eat anything. I'm just telling you about monounsaturated fats. Monounsaturated fats actually increase LDL receptors on your liver. They increase LDL receptors, kind of like a PCSK9. Yeah, kind of like that. Wow. I don't have a PCSK9 problem. I have an LDL receptor problem. So if I decrease saturated fat and increase monounsaturated fat, I'm going to increase LDL receptors on your liver, and the LDL will jump out of the bloodstream, go through the windows and the doors of the liver cells, and get back inside for the liver to deal with it. Either you mix it with bile and have a bowel movement and get it gone, or you recycle it and reuse it because you need it. Okay? This is a big subject with a lot of nuances, and we are not looking, the doctor's just looking at an LDL and saying, here's your medicine. Well, why, doctor? Do I have a problem? Do I have a PCSK9 problem? Do I have an LDL receptor problem? Do I have an NPC1L1 problem? Oh, geez, what is that? Now, Lucy mentions avocados for monounsaturated fat, but you're going to talk to Lucy. You're going to say, you got some, stealth carnivore you're talking to in the gym, and they're going to say, I'm not eating an avocado. That's a plant. I don't need that stuff. So you got to give them some options. How can they increase their monounsaturated fat and not eat a plant? Give them some emu fat. Emu fat is very high in monounsaturated fat. What about lard? High in monounsaturated fat. What about duck fat? Duck fat's very high in monounsaturated fat. So now you didn't get off your carnivore diet. You just substituted your butter with emu fat or duck fat. You just drizzled, instead of eating a fourth a stick of butter, you add a fourth of stick of emu fat or duck fat or lard. You increased your monounsaturated fat, you recheck in 3 months, and your LDL has come down miraculously, and you're still eating carnivore. Amazing. And you didn't eat any plants, which increase inflammation. Okay. Yes, Silja asks, increasing LDL receptors is why you are eating 7 macadamia nuts. Yes, I chose macadamia nuts as my own little experiment, okay? Then I'm going to recheck my labs, okay? I'm going to recheck and see if the macadamia nuts, between 7 and 10 of them a day, is affecting my LDL, okay? All right. And then if it doesn't, do you increase the macadamia nut number to 12 or 14? Because that's what a serving size is. That's why I came up with that. Somewhere between 10 and 12 is a serving size of macadamia nuts, which should give you a certain amount of grams of fat. And then it keeps me knowing how many fats I'm consuming. All right? Macadamia nuts are high in monounsaturated fat. Any questions so far? Is the person who's metabolically stable, again, when I say that, I mean they have low blood pressure, they have low blood sugar, less than 100. Their waist size is under 30. Let's just say it's for everybody, it's under 30. Okay, let's just say 35, just to give you a little bit of leeway. Under 35. Your blood pressure is under 140/90. Your triglycerides are less than 70, HDL greater than 70. You're metabolically stable. You get an NMR and you have high, small, dense LDLs. That would be the person I would say, hey, we need to look into changing some things. Tell me how much fat you're eating, how much protein are you eating, what are you eating, okay? If you tell me, the saturated fat content is pretty low, I'm gonna actually be also asking you about your stress, your job, your sleep, your marriage, your kids. I'm gonna ask you about everything. I wanna know about your lifestyle. I wanna know what exercise you're doing. Are you running a marathon every day or a half marathon every single day, Monday through Friday, for the past 40 years? I'm going to tell you that your risk of having a problem is pretty high. Okay. What about an aortic aneurysm? What about it, Kevin? What is your question about your aortic aneurysm? An aneurysm is out. When an aortic aneurysm reaches about 6 centimeters, doctors get a little worked up and say, maybe we should go in and repair this aneurysm. That aneurysm could be hereditary, where you just have a weakening of that area. You could have had high blood pressure, which weakened the area. And most times, an aortic aneurysm can be just simply monitored, and it should be monitored, okay? The doctor that says it's 4, I'll see you in 5 years, I would not do that, okay? I wouldn't do that. I would never let it go that long. What if you got angry one time, right? You blew a fuse, you blew a gasket. That's what I like to say. You blew a gasket, you got pissed, you got road rage. Your platelets became reactive, the pressure went up. You now have an inflammatory event, a blood clotting event, your aorta busts, and you bleed to death. Just because you got road rage, just because you got angry. Nobody looked at your clotting factors. Nobody looked at your aorta. Nobody looked at anything. We can find out a lot just by getting a calcium score. We can see your lungs in a calcium score. We can see incidental findings. I hate that we have to get a diagnosis every time we do a diagnostic test, but sometimes it can be good. All right. For you women out there who get mammograms, we can see a lot. We can actually see calcification in your spine. Okay. We can see calcification in your aorta. So incidental findings just on a simple mammogram, yeah, it's sometimes can be a good thing, right? Okay. Yes, freaky, huh, Kevin? Well, it could be, but maybe there's a possibility, Kevin. Let's just say that you just found out you had an aortic aneurysm, right? And it's 4, all right? Let's just say it's 4, okay? Well, how long has it been 4? Maybe you got that aortic aneurysm when you were 20 and now you're 50. It just depends. It's all, again, I would like to know more information, okay? Okay. Super Nana says, no statins for me ever. What, you guys, let's talk through this. What would be the reason to even use a statin, despite the fact that you could get some memory problems, diabetes, muscle aches and pains, and there's probably only a 0.5% decreased risk of having a heart attack or stroke if you've never had an event. What did you just say, Dr. Jensen? You heard me. If you've never had an event, the studies, absolute risk reduction is less than 1%. You would have to, it's less than 1% that people will have an event. Statins do not help, okay? Somebody just had an event. I don't know if that was a bowel movement or a pee episode. We have Buddy is still not trained. So I heard something and we'll have to clean it up later. He's usually on my lap, but today he decided he would just like to lay on his cozy little bed. Yes, do you hear us talking about you? Do you want to jump up? Can you jump up? Mm-hmm. This is the culprit right here. That is the culprit. Got to get your foot off of the table. Where were we? Where were we? We were on the aortic aneurysm. We're talking about LDLs. We talked about small, dense LDLs. We talked about high amounts of saturated fat versus, we'll put you down, I think he will, versus monounsaturated fat. Keeping our temper under control, right, Kevin? That was it. Thank you, Sarah. Appreciate that. I think he must have had a smelly diaper because that's what it smelled like, so we'll have to clean that up. Nick says, I eat fish and chicken for my protein, vegetables, and a smoothie in every meal. However, I've been on an SSRI, selective serotonin reuptake inhibitor like Lexapro or Zoloft or Paxil or Prozac or something like that for 12 years, recently off of them and have lost 14 pounds. I'm hoping this will lower what? Lower, did I miss it? No, I don't know. It's going to lower something. So, yeah, until I know what's going on, is there a question in there? Brenda says, PCSK9, is that hereditary hypocholesterolemia? I have hereditary hypercholesterolemia. Is that harmful if I am eating a high-fat keto? So, Brenda, is your hypercholesterolemia, you've had it checked, you did a FH panel, which will check PCSK9, ApoB, and your LDL receptors. That is what an FH, familial hypercholesterolemia panel, will give us, okay? So you have found out that your PCSK9 is one of the three that is disruptive. So you have high PCSK9, which is lowering your LDL receptors on your liver, leaving LDL to be stuck circling your liver, your house. It needs to get back home, the LDLs, but they can't because there's not enough receptors. You've been tested and you have high PCSK9 and it's lowering your LDL receptors. So do you take a PCSK9 inhibitor? You could. Would that be the optimal treatment to lower PCSK9? That would be the absolute best situation or scenario why you would use a PCSK9. Okay? But you know the diagnosis. Now, Brenda goes on to ask, is it harmful if I'm eating a high-fat keto diet? I'm guessing your high fat is saturated fat, or is it monounsaturated fat? If you, Brenda, have high PCSK9, which is lowering your LDL receptors on your liver, do you add more saturated fat that will lower your LDL receptors on your liver even more? The answer should be no. You need monounsaturated fat and less saturated fat. Does that mean you can only eat chicken, turkey, and fish? No, because those don't have things in them that you need, which is heme iron. We need some saturated fat, but you don't need to completely go off of red meat. You just choose leaner sources. You would be able to tell if you eat a saturated fat diet, high in 80-20 ground beef and ribeyes and New York strips, your LDL is going to go up. And you already know that you have a hereditary high amount of PCSK9. I'm guessing you had that checked. I'm going to speculate. I'm going to assume. And that will lower your LDL receptors. You don't want to add to you don't want to pour more fuel on it by eating more saturated fat, which lowers LDL receptors. You want something that's going to increase LDL receptors, monounsaturated fat, PCSK9 inhibitor. Those are two things that will increase LDL receptors on your liver. Okay? You have a condition that caused low LDL receptors. So if you got a high PCSK9, I'm guessing your LDLR level will be low. Nick asks about the new Lipfendra, and that's how we started out today. That's our question from yesterday was, can you discuss the new oral PCSK9 Lipfendra that was recently in the United States approved for LDL reduction? I don't know what your question is, but if you want to go back and re-listen to this live stream, we talked about Lipfendra. Okay. Brenda says, I'm mostly animal-based with a few veggies. So hopefully I answered your question, Brenda. Nick says, my triglycerides are 513. The very fact that you have elevated triglycerides tells me that you have elevated VLDL. And at 513, you have to be eating a lot of carbs. Or you have a problem genetically with high triglycerides. Okay, what is it? We don't know. Do you give a PCSK9 inhibitor for triglycerides? No. That's not the mechanism of lowering VLDL. Your liver can't take up the LDL out of your bloodstream if you need a PCSK9 inhibitor. You don't take a PCSK9 inhibitor to lower VLDLs, which have triglycerides in them. So I don't know why, Nick, that you have high triglycerides, but there's got to be a reason. Hold, please. Stop. Stop. Thank you. You were up here once before and you were not wanting to be, let's see, my LP little a was 22 in November. Okay, it's less than 30. It's pretty good. I would need a lot more information to, help you explain risk factors and chances for cardiovascular disease. Okay. In April of 2026, it was 95.4. What caused the big jump? A different lab? Simply a different lab. So does that tell you Ariva's love? I'm sorry. We'll call you Lovey. What if LP little a is genetic and it's fixed? Why did yours go from 26 to 95? That seems odd. Or 22, I think it was. 22 to 95. That's really odd, isn't it? But I would like to really know, what did your VLDL do? What did your triglyceride do in that time period from November to April? And did you use the same lab? And did you fast the exact same amount of time? And did you get your labs tested at the exact same time as the time before? And why would your doctor have ordered an LP little a when they know that it's genetic and you only have to test it one time? Why would they have gotten it again? Who would have thought to check LP little a 6 months later? I don't know. Brenda says, since your triglyceride is low, you're likely not at risk for cardiovascular disease. Correct. Triglyceride low being less than 70, HDL high being greater than 70. No blood pressure problems like 120/80 or less. Your waist size is less than 30. Your blood sugar is less than 100 and your insulin is between 3 and 5. Now is your cardiovascular risk less? Yes. What if you have small dense LDLs? Well, that's one risk factor. What if your LP little a is above 30? Well, there's another risk factor. What if you're menopausal? Yep, another risk factor. Why? Because menopause decreases the LDL receptors on your liver. That's why women who are postmenopausal have higher cholesterol, because their LDL receptors go down. So now you have 3 different things, Brenda, that could be lowering your LDL receptors. You have high PCSK9, you're postmenopausal, I'm guessing, I don't know, and I just made that up, and you are eating high saturated fat, over 100 grams. Lower it to 50 and increase 50 grams of monounsaturated fat. Oh, that's what we're going to talk about, Miss Young. Why would you want to take a statin? So Miss Young says, statin meds are the biggest scam, so is standard of care. Well, I can't disagree with you, okay? But I was bamboozled by the buffoonery in my time, and I, drank the Kool-Aid and didn't want to get sued and was an obedient little doctor following all the rules that they set up for us and under standard of care. And we followed a little recipe, and if your LDL was this, you get this, and if it's that, you get that, and on and on and on. But why? What could you possibly want to take a statin for if you knew that it could cause brain damage, cause diabetes, mess with my muscles? What would you like to do? What would a statin do for me? Well, 2 things. Yeah, James, I agree. 2 things. It's antithrombotic. It's going to help you break down clots. Well, why do you have clots? Well, I don't know. Well, what's your LP little a? Okay. What is your PAI1 inhibitor level? What is your fibrinogen level? What's your factor 5, factor 8? Are you at risk for blood clots? Are you a pissed off, irritable, every single minute of the day person? And you got reactive platelets? Is anybody looking? Why don't we change those things instead of just going with a statin? But I'm giving you the reasons why you would want a statin. Antithrombotic. You don't want to change anything else. I don't want to have a heart, or I don't want to have a blood clot go to my brain, so I'm going to take a statin for the blood clot. Okay? And I'm going to take an aspirin. Okay? We covered that. So you're willing to accept the risk factors to decrease your risk of having a blood clot. Yes, I am, doctor. What would be the other reason you would take a statin besides antithrombotic? Well, it's anti-inflammatory, which begs the question, why is your inflammation high? Well, doctor, I don't really want to stop eating carbs. I love them, and I'm addicted to sugar, and I'm not going to change. I'm going to eat a crapola diet for the rest of my life. Then you are well informed, and go for it. Hopefully your statin will keep your inflammation down, and hopefully they didn't choose one that crosses the blood-brain barrier that really accelerates your brain damage. Oh yeah, doctor, I'm all about that. I'm on Crestor. Oh, good. Okay. Great choice. You're welcome, Brenda. Nick, my triglycerides. What about your triglycerides? What about them? They're 500. How did you get them? Do you have a genetic problem? Lipoprotein lipase. What is your lipoprotein lipase level? Are statins essential? Essential, meaning without them, we would have a problem. Are statins essential to stabilize the soft plaque, which I am told is more of a risk? I have 40% calcification in my LAD, left anterior descending, okay? On no medicines at the present time. Trying to manage diet and lifestyle, okay? KK, do you know what try means? When somebody uses the word try. KK invites me over for dinner. I say, KK, what time are you having dinner? And KK says, 6 p.m. And I say, I'll try to be there. What does that sound like to you, KK? Am I even going to come? Or am I going to be late? Or am I going to be early? We either do or we don't do. I know it sounds like, Dr. Jensen, you are hardcore and you're not giving me any options here, but it's your body and you are the one trying. Now, to answer your question, do statins stabilize a plaque? Do they cause more calcification? The answer is yes, of course. But if you were to re-listen to the entire live stream today, is that really our goal? Is when we take a statin, it increases our calcification because they told you that it must be stabilizing soft plaque. But if you don't take a statin and you have a high calcification, it's bad. It's good if you take a statin and you get more calcification, but it's bad if you have calcification and you're not on a statin. One way good, one way bad, depending on if you take a medicine or not. Right, Kevin? Kind of sounds sketchy, right? Good if you're taking a statin. That just sounds weird to me, right? What if we just checked a person who's not on a statin and they're at 100 and we check a person, let's just say we have a calcium score of 100 and we have 2 people with 100 and we don't give anything to one of the 100 people, and in 5 years, 3 to 5 years, it's 125. And we had a 100 and we put that person on a statin and they get a 125 in 3 to 5 years. But the person on a statin and a 125, raising up 25 points, is good. But the person not on a statin who went from 100 to 125 is bad. I mean, help me understand that. Help me understand that. I don't understand. My question to you is, you have 40% calcification. Is it really 40%? Or you just have calcification? Calcification of, how did they get the number 40%? Because it just shows if you have calcification. It doesn't show I have a 40% blockage. I mean, you could have 40% calcification for the next 10, 15, 20 decade, 3 decades, right? And it didn't change. Do you take a statin and increase that? Well, I don't know. I got soft plaque, don't I? How did you get soft plaque? Well, a blood clot. How did you get a blood clot? Well, I kind of eat a lot of sugar and I smoke. And I've been known to drink some alcohol on weekends. And I don't exercise. Do we take care of the soft plaque? Do we look at blood clotting factors? Do we look at all of the things that cause an injury? Or do we just jump to a statin? I don't know. I guess you have to make that decision. So KK was told that if they took a statin, it's only going to increase 15% more calcification at the most. Where did they come up with that number, KK? Did you ask them where they came up with these numbers? I mean, it sounds like buffoonery. And it's bamboozled you because you're asking the question. So you've been bamboozled by the buffoonery. They made up some number like 15%. I don't know. Is there a study? I'm not aware of one. If you bring it to me and says, if you take a statin, there's a 15% more calcification that's going to occur. And it's going to stabilize and it'll be all good. Calcification with a statin, good. Calcification without a statin, bad. I'm having troubles, you guys. I don't know. One French poodle says, my cholesterol's 231. My LDL's 117. Triglycerides 45, HDL 100, triglycerides 45, HDL 100. Should I be concerned? I eat 0 processed. So 0. Chicken, fish, veggies, nuts. With that number, a triglyceride of 45 and an HDL of 100, less than a 1 ratio. Metabolically, I'm going to guess that their waist size is less than 30. Their blood pressure is 120/80. Their blood sugar is less than 90, and their insulin is between 3 and 5. I'm going to guess. I don't know. I'm going to guess their CRP is less than 1 as well. I'm going to guess that their homocysteine level is 8. Do you see how many factors I would need to look at, plus more, to really decide, does one French poodle with an excellent metabolic panel at low risk? I guess me personally, I want to look into it further. Just painting with a broad brush stroke right now, yeah, that looks beautiful. Beautiful, one French poodle. And I bet your French poodle's beautiful. KB says, can I listen to this session again? Is it stored? Yes, if you go to my channel, which you're on right now, and you go to the grid, it'll be in my Michigan shirt with my hair pulled back on a little bun with these glasses on. And you can re-listen to the whole, so far, an hour and 20 minutes. So yeah, you can go back and re-listen to it, KB. Nick says, I believe my high triglycerides are due to long-term SSRIs. That is a strong possibility. In fact, antipsychotics increase triglycerides even more. So the body is making VLDL to store cargo of triglycerides and LDL and send it out into the bloodstream. Nick goes off of the SSRIs, rechecks, and it goes down to 400. Well, geez, that's not a big change. Well, then I would say, what are you eating? Okay. Now, if your weight, which Nick says went from 170 to 220 over 12 years, 50 pounds increase in a 12-year time period, you don't just gain weight by taking a medication. You gain weight by eating something. You don't make triglycerides simply by the medicine. You have to eat something that helps to make the triglycerides. I'm guessing your insulin level went up. Insulin goes up with stress. I thought the SSRI was supposed to lower my stress. It doesn't lower cortisol. right? Insulin goes up with what you eat. And if you are a stressed, anxious, irritable, mad, angry person all the time, cortisol's going to go up, adrenaline's going to go up. Oh, I drink coffee too. Oh, cholesterol's going to go, or cortisol's going to go up, and adrenaline's going to go up. Blood sugar goes up, insulin goes up. You get fatter. You need energy taken in, yes. But if insulin is high, any little bit of energy you take in the form of anything from hand to mouth is going to cause you to gain weight. You can't just take insulin and get heavy. You have to take insulin and take in energy at the same time. It's just that insulin tells you where it's going to go. Okay? So Nick, they're going to put him on fenofibrate for his high triglycerides. The only medicine that can lower triglycerides, and a pretty good amount so far. We could give Visipa, which is an EPA omega-3, and that would be a good choice and a safer choice than fenofibrate. But again, that's up to Nick. But I would figure out why is it elevated in the first place? I want to know why. Is it the SSRIs? Then if it's SSRIs, no reason to take a medication. It'll be down less than 150 because you're on a low carb. It'll be less than 70 because you don't eat carbohydrates and you are off of the SSRI. Yeah, I get it, Nick. Nick is scared of pancreatitis. High triglycerides, pancreatitis. Right? Inflammation of the pancreas. Pumping out a huge amounts of insulin. I would definitely work on my diet. Homes by Julissa. ApoB is 125. ApoB is a protein. Come on, bud. Come on, up. ApoB is a protein that's found on every LDL. Are we going to be nice this time? Yes, you're always nice, I know. ApoB is on every LDL, every VLDL, every LP little a. Oop, you're going to fall, bud. You're going to fall. You're going to fall. There we go. Cuddle up. It's on every VLDL, every IDL, every LDL, every LP little a. ApoB covers everything. If you have very, very high VLDLs full of triglycerides, then your ApoB is going to be high. Does that mean it's all LDL? Absolutely not. Do you need an NMR to decide? Yes. Your CRP is 1.9. That's high. It should be less than 1. So you have inflammation going on. Your small dense LDLs are 266. I don't know the level, but I think that's low. I think if it's over 400 or 500, I can't remember, okay? I don't have an NMR reference range in front of me. LP little a is 196, another risk factor. So you have a risk factor for blood clots with an LP little a of 196. You have an increased risk of blood clots if you have an injury. Do we think you have an injury? We must have some sort of an injury because your CRP is 1.9. And I would get, if I were you, an L-plaque, an LP-PLA2 level. And it will give the inflammation of your arteries. Could you get a SED rate? Yeah, but it's not as specific. Could you get an IL-6? Yes, you could. But get an LP-PLA2. Even though your triglycerides are only 40 and your HDL is 78, metabolically with an A1C of 5.2 looks awesome. And a zero calcium score. Should I not be on carnivore diet? No, you are on a carnivore diet for your own reasons. It isn't a reason to go off of a carnivore diet, but with your LDL, small dense LDLs, again, I just need that reference range. I think if it's over 400 or 500, it's on the elevated side. So if it's not elevated, your small dense LDLs are not very high, okay? You just have an LP little a of 196. If I was you, I would get a fibrinogen level, a factor 5 level, a factor 8 level, a prothrombin level. I would probably get a D-dimer. I would make sure I don't have risk factors for a blood clot. I already got one, LP little a. I'm guessing, Holmes by Julissa, I'm guessing, Julissa, that your waist size is under 30. Okay? Now, again, if you want to lower small dense LDLs, decrease saturated fat, and increase monounsaturated fat. Okay? All right. Okay, so I have great questions. If I was you, I'd stay on carnivore. Your blood pressure is stellar, says Mrs. Young. KK says, no, the lifestyle intervention. Okay, I don't understand. Okay, one French poodle. Wow, my husband had a calcium score of 509. They put him on Repatha. I could instantly tell in the first month him having slight memory issues. So 4 years later, his calcium score is higher. You know what I would want to know more, one French poodle? I would want to know his liver function. I want to know his ALT, AST, and ELK-phos, alkaline phosphatase. ALT, AST, and alkaline phosphatase. I want to know if his liver is plugged up, okay? If it is plugged up and I give a PCSK9 inhibitor or any of these new medicines that increase LDL receptors on the liver and take in more fat into a fatty liver already, we are going to cause a lot of fibrotic livers, which leads to cirrhosis, and people are going to be on the transplant list, which, by the way, people have to die in order to give their liver to someone who needs it. I wonder who gets rich off of all of that. I don't know. It's okay, KK. I don't know what a 15% improvement is either. So I think we're being bamboozled by all of these percentages, and they're more along the lines of a relative risk reduction instead of an absolute risk reduction. Okay. Is there a better thrombolytic than statin drug that is readily available? What would help break down fibrin? Well, you could take Coumadin, warfarin, you could take Xarelto, you could take Eliquis, they're thrombolytic. You could take an aspirin. You could take nattokinase, lumbrokinase, serrapeptase. I don't know about the studies on those latter two. I think there's only been one lumbrokinase study in 2013. I believe I spoke about it a couple weekends ago. Nattokinase, there's a recent study, 2022 maybe, on decreasing plaque formation. So that would be meaning decrease the fibrin content of your soft plaque, and that lowering soft plaque would stabilize or even lower your hard plaque. Possible. It's possible. John says a friend of his just passed away of liver failure, waiting on a donor. Nobody really wants to give their organs anymore, John. Have you heard on social media that you must be labeled as brain dead, can't come back, but yet you're still alive? So we got to take your organ when you're still alive, knowing that you're still alive. But if we don't have the organ, then you're going to really just go. So I would just want to make sure that I was really just going to go. Then you can have my organ. No, we can't do it like that. We actually have to keep you alive to get your organ. Yeah, but if you keep me alive, couldn't you have kept me alive? I don't know. So many questions. One French poodle says my homocysteine is 12.9. That's too high. That's too high. Homocysteine of over 8 is too high. What is homocysteine doing? It's like sandpaper. Sandpaper irritating the lining of your artery. You mean it's wearing off my glycocalyx? Absolutely wearing off your glycocalyx. You mean it's causing an injury? Absolutely. Could that cause a blood clot? Yes. Just from my LP little a? Yeah. Yes. Oh, wow. So I should lower my homocysteine. Yeah. Well, why is it high? I don't know. Do you have a B12 level, a folate level? Do you have an MTHFR level? Lots to be known. I would get an MMA level. Even if your B12 level is normal, maybe you're not absorbing it. Is that why I keep taking B12 and my homocysteine level doesn't go down? Yep. You can't absorb it. Okay. Nick says insulin is fine. So your insulin is between 3 and 5. Is that right, Nick? When you say fine? Julissa says, yes, my waist size is under 30. Can breast implants be the cause of my CRP? Absolutely. It's a foreign body. Yeah, it's a foreign body in your body. And your body's reacting to it. Yuli says, does atorvastatin cross the blood-brain barrier? Yes. Which ones are doing that and causing a risk for damaging the brain? So most commonly is atorvastatin, Lipitor. It is used, and actually doctors are so smart now, they know that Lipitor crosses the blood-brain barrier because it's lipophilic. So if it crosses the blood-brain barrier, then our brain cells, which also have a mevalonate pathway in them, the Lipitor will block not only the mevalonate pathway in your peripheral body, but it'll block the mevalonate pathway in your brain cells. Oh, geez, that doesn't sound good. I know, right? Then there's no CoQ10, no vitamin D, no vitamin K. There's nothing up there. So yeah, the lipophilic that cross blood-brain barrier, which one doesn't? Maybe the Crestor, which is the rosuvastatin, would be a better option if you're going to do a statin. That was a good question. Thank you. John says, Doc, my AST and ALT are 8 and 13. I would say that's pretty good. When ALT starts getting that low, I check people for a B6 level, okay? Most docs will say, hey, yeah, your ALT, AST is good. But you really are kind of showing a reversal, a trans... You want a 1-to-1 ratio of ALT to AST, okay? And yours look normal on the surface, but again, I would get a B6 level, okay? Yeah, like a baby aspirin, Kevin. Yep, thrombolytic. So Vic asks, why would white blood cells be low other than leukemia? So you don't have leukemia. And you're asking, why would my white blood cells be low? I would think about, of course, I would think about immunity. I would think about the bone marrow and how the bone marrow makes your blood cells, red blood cells, okay? I would want to know your iron levels. I'd also want to know your thyroid. Peace always says a thalassemia. So somebody on YouTube is helping us out. I guess I would need more labs to look into why your white blood cell count is low, why your immune system, is your LDL low? You know, higher LDL, better immune system. Holmes by Julissa says, do I need to take an aspirin for my high LP little a? Or maybe take nattokinase if you don't want to take an aspirin. Okay. Julissa, do you happen to know what your blood type is? Blood type. Do you know what that blood type is? Remember, I talked about maybe a couple weekends ago that nattokinase works better in an O-positive person. It takes a lower dose of nattokinase to work in an O-positive person. it needs more dosing if you're AB negative. If you're AB negative, it's going to take more and more nattokinase to work, if it's even going to work. Is this written in stone in a study? No. But it's getting studied, and nattokinase is cheap, and pharmaceutical companies are not going to be running studies on a fermented soy from a soybean, a Japanese soybean, okay? They're just not going to do it. There's no money to be made in that, okay? But this is for your own benefit. And if you are O positive, I would say, hey, nattokinase might be a good bet for you. At what dose? Maybe 4,000. Well, what if I was O negative? Well, you might need 6,000. Okay? Well, what if I was B? So it's O positive. It goes like this: O positive, O negative, A positive, A negative, B positive, B negative, A. No, it's actually B before A. It is. Ah, shoot, you guys, I'm sorry. But I just know AB negative is the worst. Nattokinase probably won't work. And if it does, you would need 20,000 units. I just made that up. I don't know, but it's over 10,800. How about that? That was because the study was done on that in 2022. 10,800. I don't know what their blood types were. And somebody looked up the study on PubMed and said they didn't look at blood types. Okay? But the positive means you have an extra little protein that helps the nattokinase work. Okay? The negative means you don't have it. You don't have that extra little protective protein. You're welcome, John. John's going to check his B6 level. Yeah, Lucy says, hit the thumbs up. Can you guys hit the thumbs up? It would help. I appreciate that. Also, if you guys want me to look at your labs in depth, we can do a consultation. Email me at ironladydoc@aol.com. ironladydoc@aol.com. So if I'm AB negative, don't bother taking natto. Maybe not, Allison. Maybe you would benefit more from taking lumbrokinase instead of nattokinase. Lumbrokinase is a little more potent. It is a proteolytic enzyme that does help break down fibrin. So it's fibrinolytic, and it acts it acts whenever it sees a fibrin clot. So if you have a lot of fibrin clots going on, lumbrokinase is going to be working overtime. Nattokinase basically just works all of the time, lowering fibrin. Okay? So Allison, if you're an AB negative, maybe you do some research on lumbrokinase over nattokinase. Just do some research and say, some dumb doctor online mentioned blood type AB, negative, not nattokinase not going to work as well, and see what you find out. And then you can tell us if I was completely full of buffoonery in my bamboozled head. All right. What other, did I miss any questions? Julissa is an O positive. So Julissa, you're going to react much better to nattokinase than Allison. So nattokinase, even at lower doses, maybe between 2,000 and 4,000. Again, do I know these numbers are written in something? No, I'm just giving examples, okay? The study was done on 10,800 FU, fibrinolytic units, and anything below that did not work, did not show benefit. But we don't know, maybe all of those people that needed 10,800 were AB positive or AB negative. We don't know. We don't know. But if you're O positive, my thought process would be even lower dose of nattokinase would be beneficial. Okay. Allison said, okay, you're going to look up lumbrokinase for me with your with your AB negative blood and see what you find. That would be awesome, and then you can let us know. I don't think, this is why science is so beautiful. It's never written in stone. It's never settled. And if somebody tells you that some study was scientifically settled everything, oh my gosh, just walk away. That's the whole premise of science, is we think of, we research something, we look it up, we do things, we have other thoughts, we make a hypothesis, and then we try to test the hypothesis, and then we make a theory out of it, and we do all of these things, and it's just ongoing. Today, potatoes are bad, and tomorrow they're wonderful for you. Eggs are good, eggs are bad. Seriously, if somebody tells you that science is settled and LDL is the cause of heart attacks, you know what? My thoughts are, I would say, oh, brother. That's what that would be, but I'd probably say it under my breath, okay? You're welcome, Julissa. Okay. Jason, I don't have a thought on Wisconsin and the governor and allowing 18-year-olds to get methadone. It kind of sounds shady. I don't know anything about Wisconsin. And, I'm personally not wanting to put drugs in my body, so. Yeah, if you have Kevin asks, what do you think of melatonin? I think that we need it in order to get restful sleep. It's a hormone that's produced in our body, melatonin. It goes down with age. It goes down with light exposure, especially blue light exposure, especially at night. It works on our circadian rhythm. So if our circadian rhythm is basically sunrise to sunset, melatonin is going to work fantastic in your brain. I think there are reasons why melatonin goes down besides age. And I think a lot of it has to do with our lifestyle. Do I believe in taking melatonin? I go back and forth, and I would want to know what type of person I am using melatonin on. Initially, my thoughts would be, I don't want to give somebody melatonin if they are a stressed out, hypervigilant, ruminating thoughts going through their head. I'm thinking, I can't tell you why at the moment, but I'm thinking that probably would not be a person I would treat with melatonin, okay? I can't even tell you the reason why, but something in my heart tells me not to do that. Pin the consultation, I have to hop off. Okay, all right, so pin the consultation. Pin the consultation. If I can pin the message, there we go. Okay, so I pinned it. Lucy's got to go, she's my blue wrencher. Okay. The only science that is considered settled is called a law, and there are very few laws. Well, there might be a lot of laws, they're just not even followed. Jason says, thank you for your opinion. I believe in all natural medication. Unless the doctor says otherwise, I like to take herbs. But what are you taking herbs for, Jason? Is there a reason? Have you been tested that you need a special herb? Were you deficient in an herb? Oh, Julissa says, what do you think about bioidentical HRT? Bioidentical to what? What is it bioidentical? Does that mean man-made and I made it look like a natural hormone? Which it can look kind of like it, but bioidentical hormones are basically plant hormones. So they're phytosterols. They're not cholesterol. We are an animal, and a plant is a plant. And doctors think that they can take a plant, and they made it sound so beautiful by saying it's biologically identical, although it's not. I mean, one comes from a plant and one comes from a mammal. So you're bioidentical hormones are phytosterols that you think can incorporate themselves into our cell membranes. Remember, all of our cells are made of, the membranes are made from cholesterol. They need cholesterol, or else we would fall like a heap on the floor. They need cholesterol. We would die. But man thinks that we can take not cholesterol and we can give you a phytosterol and incorporate it into your cell membranes and think that your cell membranes will just act like, oh, well, this is normal. I'm an animal and I'm going to put a plant sterol in my cell membrane and I'm going to function perfectly until it causes what? Oxidation, because it's a double bond. I don't know, you guys. This is why I don't consume plants. I don't want polyunsaturated fatty acids. I don't want plant sterols in my cholesterol membranes. I want cholesterol in my membranes. I don't want plant sterols in my membranes. But again, this is my body. Julissa, you have your body. And if you want to do HRT, do HRT. She feels that she needs to be on something for her perimenopause, not feeling good at all. Yeah, Julissa, we can talk about it during a consultation if you'd like. But, and again, it has to be where you know all of the, you have informed consent. You have enough information that you can make a good decision for you. If you say, I would rather feel good and have phytosterols in my cell membranes and feel good for the next 20 years and live like that than to live miserable and not have phytosterols in my membrane. Everybody needs to make the decision for themselves. What Dr. Jensen would do and what Julissa does, it isn't, you need to do what's good for you. I don't want to tell you what to do. What would I recommend instead? I would find out why I felt terrible. I really would. I would check all of my levels and I would find out, do I simply just need to exercise more? I don't know. I just made that up too, okay? I'll tell you when I make stuff up, by the way. I'll just say, yeah, I don't know where that came from, out of my head. Let's see. Looking and make sure we don't have any other questions. Looks like we had some riffraff. See, the minute Lucy goes away, we get riffraff. Riffraff. Especially on YouTube. Okay. All right, that looks like all of the questions. Hopefully I didn't miss any. All right, you guys, this is it. Before you leave, hit the thumbs up over there on YouTube, okay? All right, since there's no other questions, we shall, let me make sure. Oh, KB says, did you just say you don't eat plants? I kind of lied, KB. I do eat a plant. I drink coffee, and I told you earlier I eat macadamia nuts right now, temporarily. 10 to 12 of them. So do I eat plants? Yes, I do, currently. Okay. Let's see. How do I feel about berberine and citrus bergamot? I don't know how I feel about them. What would you be using berberine for or citrus bergamot for? Do you have a deficiency of berberine or citrus bergamot? You have a deficiency of them, so then do we take that? Have we ever looked? KB says, broccoli? No, broccoli is a goitrogen. It's a cruciferous vegetable. It's a goitrogen. And that means it affects my thyroid, and I don't consume them any longer. Peaceful says, for heart health, I take berberine and citrus bergamot. But what is the mechanism of action that it improves your heart health? Doesn't berberine act like metformin? Is metformin healthy for your heart? Or is metformin a mitochondrial toxin? Is it possible that metformin used for diabetes is a mitochondrial toxin? Yes. Do we necessarily want to take metformin if it is a mitochondrial toxin? Yeah, but I got diabetes. Well, before you started the metformin, couldn't you just remove the diabetes by stop eating the toxin that causes diabetes? It's quite possible. Do I need berberine for that? No. So what else does berberine do? Well, it lowers my blood sugar. Why is your blood sugar high? Well, I kind of want to continue eating sugar. Then take berberine. And if it can help you not have diabetes, which causes heart disease, then I guess you're protecting your heart. Yuli says, is avocado a good source for monounsaturated fats? Yes. Instead of macadamia nuts? Sure. Yep. Perfect source of monounsaturated fats. I'm not a big lover of avocado. I've tried it. It just seems, I don't prefer it. I know a lot of you do. So I think I missed something else in here. Peaceful, any other comments like Peaceful Gate? Help me out. Let's see. Yeah, you're welcome, Yuli. You're very welcome. Kevin says, thank you. Hopefully that will help. I hope so too. Linda says, QQ, acid reflux is getting worse at night. I have to keep Tums beside the bed. Also on Pepcid for a hiatal hernia. Okay. So not all people with a hiatal hernia have reflux. Not all people with reflux have a hiatal hernia. Why is Linda having reflux? Is something wrong with her lower esophageal sphincter door that doesn't close at the bottom of the esophagus, that stays open and allows acid stomach contents to splash up into the esophagus and cause heartburn, reflux esophagitis? Does Linda have a big belly that is causing pressure on the lower esophageal sphincter, keeping it open? Is Linda have something in her diet that is preventing the lower esophageal sphincter from working? What is going on with the stomach contents? Why are they staying in the stomach longer, maybe longer than they normally should? Is Linda on a GLP in order to lose weight, which causes slowing peristalsis? It slows stomach dumping contents into the small intestine, so it allows the stomach contents to stay in the stomach longer, which would give it more reason to splash up when you lie down. Does it splash up when you sit up in your recliner chair? Maybe you need to put your whole bed on an incline where you raise the head of the bed with like 10 bricks, so you're sleeping like this instead of like this. You can see where acid could just splash back and forth all night long, and you taking Tums, which is a histamine blocker, does nothing for the splashing back and forth. It does nothing for the esophageal sphincter. So Pepcid is simply just a histamine blocker. I don't know, Linda. I don't know what your diagnosis is. Okay. Grandy says, how can you lower inflammation? What is the cause of your inflammation first? Is it smoking? Stop smoking. Is it alcohol? Stop drinking alcohol. Is it eating seed oils? Stop the seed oils. Is it eating carbohydrate? Stop the carbohydrates. Is it stress? Stop the stress. I don't know how to lower your inflammation, but hopefully those ideas helped you. Linda says, my dad had some condition, my waistline about 35 inches. So you have an obese abdomen, and that obese abdomen causes pressure on the lower esophageal sphincter. Plus you have a hiatal hernia, which increases your risk, could increase your risk, but not all hiatal hernias cause reflux. Again, I can repeat that. But having an obese abdomen can increase reflux and lying flat. Okay? And whatever particular diet that you're on could be also increasing the weakness of the lower esophageal sphincter. There's back to nature. Back to nature in Port Harcourt, Nigeria. Back to nature is listening from Nigeria. Never been there. Been to Uganda. Have I been to the Congo? I don't think so. Have I been to Ethiopia? No. Uganda. Northern Uganda. Yeah, northern Uganda. All right. All right. Now I think we've gotten all the questions. Okay, you guys, as a review, this was a good one today. As always, I love talking about cholesterol and LDL and PCSK9 inhibitors and statins and diabetes and cardiovascular disease. I love it. I love it. I thrive on it because I just want to keep learning more and more and more. Okay? I want to learn about how our diet affects all this, and our exercise and our sleep and all of it, our stress and our anger and irritability and our childhood traumas. I love it all. But it's complicated, and I don't think there's one size fits all. And I'm going to keep learning, and we're on this journey together. I don't know it all. You don't know it all. None of us know it all. Science isn't written in stone, and we're on a journey together to help each other learn, okay? I just have a little more time that I can put into learning more while you guys are doing the 8 to 5 job. I'm at home studying and seeing clients. If you want to sign up for a consultation to go over your labs and your scans and your diet and your sleep and all of that stuff, email me at ironladydoc@aol.com. ironladydoc@aol.com. Okay? And sign up for a consultation. I'll send you some paperwork. You can agree or disagree or, sign up, don't sign up. It's up to you. All right? I'm going to still be here answering questions. Like Bob just jumped on and says, what are your thoughts on LP(a)? I don't know what timestamp of this 2-hour live stream we talked about LP(a), but if you want, there was a lot of good information in regards to cholesterol. But let me just tell you this. LP(a) is like a Band-Aid for an injury. It helps the injury clot over. My thoughts on LP(a), if you are worried about LP(a), don't have an injury to your lining of your arteries. Get rid of the things that cause injuries to the lining of your arteries, and LP(a) will not be a problem, okay? If it's 148, is your wife a diabetic? Does your wife smoke? Does she drink alcohol? Does she eat a bunch of Cereals and processed foods? So much to look at. If I had LP(a), that's 148, I want to know my fibrinogen. I want to know my factor 8, factor 5, prothrombin. I want to know all of the blood clot risk factors. Because if I have LP(a), what if I have fatty liver disease? Well, then if I have fatty liver disease, I have high amounts of PAI1 inhibitor. PAI inhibitor 1. PAI. Plasminogen activator inhibitor 1. I don't want that. I don't want PAI1. Why? Because I increase my risk of blood clots. Where did I get PAI1? From your fat. Which fat? Visceral fat. Is it in subcutaneous fat? No, it's in visceral fat. What about subcutaneous fat? Different hormone. Adiponectin. I think it's adiponectin. Yeah. All kinds of stuff. Is the consultation free? No. I do have to make a living. This is free. You've listened for 2 hours of my information for free. I do have to make a living. I think my charges are well worth it. And you can ask a lot of people who are on here who have done consultations with me. But all I can do is, I guess, give it a try. If you think it was not worth it, then I guess you could tell the whole world that Dr. J sucks and I wish I didn't spend the money. But you'll probably pay some other fancy place like Functional Health and give Dr. Hyman some more money, give Dr. Rivero, Sean Baker some more money. That's fine. You can choose how you want to spend your money, but not everything free is free in life, okay? This part, yeah, it's free. You didn't charge it. I didn't charge anything. Nobody gave a super chat or super stickers or nobody gave anything. It was just completely free, WOA, or whoa, completely. I do it every Saturday and Sunday. Saturday at 9 a.m. Central, Sunday at 10 a.m. Central. For free. So I'm sure that you appreciate that, and that's why you were asking, right? Instead of saying, is the consultation free though? I'm going to read it like that. Is the consultation free though? Or, is the consultation free though? See how I read that? That's how text can be read. Anyway, okay. So you guys have a blessed Sunday, and Lord willing, I will be back next Saturday at 9 a.m. Central. And until then, 1 Thessalonians 5:21-22. Test everything. Examine everything carefully. Everything I said, anything somebody else says, test everything. 1 Thessalonians 5:21-22. Examine everything carefully. Hold fast to that which is good, Jesus, and abstain to that which is evil, Satan. The Holy Spirit, if you have the Holy Spirit in you, will guide you and counsel you and lead you, your helper, to make good decisions. Maybe something I said gave you a really weird feeling, like that can't be right. Go look it up. Go look it up. Test everything. Examine everything carefully. That's what 1 Thessalonians tells us to do, okay? And Diane's follower says, yes, she will give you a great amount of information. Do it. So thanks, Diane. All right. Summer love. Is lard a healthy cooking fat? Yes. If not, do you have a better recommendation? Emu fat, duck fat, butter, ghee, tallow. Unless, of course, you have low LDL receptors and then minus the tallow and minus the butter and minus the ghee and choose emu, duck, or lard. Got it? All right. You guys have a great day, okay? See ya.